Morning. So we've learned the value of prevention. As someone who's lived through an ACL himself, I can tell you that an ounce of prevention is definitely worth a pound of cure. But what is the cure if you do have an ACL tear, or if someone you know has an ACL tear? Do we repair it or do we rebuild it? And that's going to be the topic today. We went over basic anatomy. I'll just touch upon that real quick. The ACL problem. Who should get ACL surgery? That's what we're talking about with indications. And then really, what are the options available if someone has an ACL tear? So Katie very well, went over this very nicely. The ACL is a cruciate ligament. It's in the middle of the knee. The PCL is another cruciate ligament. And basically the function of the ACL is to limit how far the tibia moves forward, or you can think of it how far the femur or thigh bone moves back. And there's also a rotational component to it. If you go back to this slide, for instance, and look at the diagram, you'll see that the femur is turning externally and the tibia is turning internally, and it's that rotation along with extension that leads to the ACL tear. So some have quoted up to 400,000 ACL tears per year. Good for an orthopedic surgeon, but bad for patients. And as you could suspect, younger athletes, unfortunately, are at much higher risk, primarily because of the sports and also just the sheer exposure. If you're constantly playing 2 hours a day, well, unfortunately, you're at higher risk. We know that it leads to decreased function, sports and decreased sports participation, and unfortunately, ACL injury can lead to arthritis down the line, even when everything is done perfectly. Perfect rehab, perfect surgery, perfect everything. We know also that surgery doesn't mean you go back the next day. There's a lengthy recovery. I'm sure all of you know that. Who needs the surgery? Active patients of all ages. So we don't limit necessarily by age. It's a whole slew of things. What is the condition of the knee in general? How active are you? What type of sports do you play? Cutting and pivoting sports in particular are going to be tough if your ACL isn't working. And if someone has continued instability despite conservative measures, that's clearly a reason to consider the surgery. And in some people, especially young people, adolescents, pre-adolescents, it's kind of difficult to assume that they will follow a conservative program and wear a brace for a year, etc. So in those people, we tend to be pretty aggressive about fixing the ACL. But what do we mean when we say we're fixing the ACL? People come to me and they say, I want my ACL fixed. Well, we don't actually fix the ACL, we rebuild it. It's called a reconstruction, and that's actually the gold standard. That's what is done 99.99% of the time. And what it means is you need to take tendon from somewhere, typically from the person, that's called autograft. Otherwise, it's an allograft if it comes from the tissue bank. You take a tendon to replace the ligament. And of course, remember that a tendon has muscle on one end and bone on the other, but a ligament has bone on both ends. And that will play a role in one of the disadvantage, if it is a disadvantage. It takes time for that tendon to undergo a process we call ligamentization. All right? You want to transform that tendon graft into a new ACL ligament. That doesn't happen overnight. And as I unfortunately have to remind patients, you can't accelerate biology. The body will heal at its own rate. So there are a couple things to consider. One is the harvest site morbidity. So if you're taking a patellar tendon, guess what? You're robbing Peter to pay Paul. So there's going to be a price to pay, and we can go over that later. So the tendon grafts typically are patellar tendon, where you take a strip of the patellar tendon in the front, but you also take a piece of bone from the kneecap and the shin bone. And guess what? That hurts a little bit. So there's that. Quadriceps tendon is another one, probably the least common. And hamstring tendon is also available. So there's a lot of redundancy with the hamstring tendons. There's 3 hamstring tendons, for instance, on the inner side of your knee, and you can easily take 1 or 2 without any significant deficiency. But the surgery means you have to create sockets and tunnels. If you look at that arthroscopic image, we're drilling a hole in the femur and in the tibia. That can hurt. That causes bleeding. There's more morbidity. and there's a greater recovery. So sports clearance at the earliest, we used to always say 6 months, but especially in the younger high-risk athletes, I try to keep them out for 9 months, if not longer. And we always have our therapists and the therapists we work with test them so that they can see for themselves whether they're really ready to go back. Because sometimes they think, oh, I can play a pickup game with my friends and I look great. But the reality is, as Dr. Vadazzi showed, if you show them videos of how they land, sometimes it's not so pretty. And the last thing we want to do is have them see the doctor again. So we like to go pretty slow. What's ACL repair? Is this really the new kid on the block? Well, ACL repairs were pretty popular in the 70s and early 80s. And what the doctors would do is make a minimally invasive incision, and by minimally invasive I mean this big, open the knee, find the ACL ends, which look like these two pieces of rope, or that one piece of rope that's torn, and basically just stitch them together. And on top of that, you'd be fortunate enough to be placed in a cast for about 6 to 8 weeks, not walk. Your leg would get really shrunken, and you'd be very stiff. And as you could imagine, the results weren't so good. And when reconstructions came out, they produced much more reliable results, and so everybody shifted to doing the reconstructions. So what's changed? Well, a lot of things have changed. The technology has improved. Some of the implant companies, for instance, are outside, and you can see some of the stuff that we'll use. Very minimally invasive drills, anchors, buttons. All that technology is really great for the reconsideration of ACL repair. There's also the Holy Grail concept. What's the Holy Grail? Well, in orthopedics or medicine, it would be you tear something or injure something, and guess what? It just heals on its own. Or you get it to heal on its own. Rather than taking a tendon from somewhere, what if the ACL could just heal on its own and go back to the way it was? That would be nice. We also acknowledge that there's probably a difference in the biology of tears of the ACL that go off the bone versus those where the ACL is torn in the middle of the ACL. The blood supply is probably better if it's off the bone because it's in the proximity of the bone. And of course, we don't torture people in casts for six to 8 weeks. We have them weight bearing immediately and have them moving their knee immediately. So who gets an ACL repair? Well, if you're even going to consider it, it's typically for very select cases. It's for tears of the ACL where, again, it tears off the femur and it's in proximity of the femur. You'll place some stitches in the ACL substance, so in the ACL itself. You'll probably drill a small hole in the femur and then drag the ACL up towards the bone. And what we'll also do sometimes is augment, or in addition to all that, we'll add what's called a suture tape. Think of it as a very flat stitch that goes all the way through the ACL to give it some added strength. But what does the data say? I mean, it all sounds nice. These are two studies. The one on the left just came out in the Journal of Bone and Joint Surgery, basically the New England Journal of Medicine for Orthopedics. And while, it's not exactly comparing apples to apples because ACL repair today is done very differently than 30 years ago, what it does show, though, is unfortunately the revision or redo surgery rate in people who had ACL repairs was significantly higher. So if you look at the bars, those who had reconstructions are basically in the yellow or white, and those who had ACL repairs are in the blue and red. They also did things back in the day where we would wrap the ACL in a synthetic graft to try and give it some added strength, and unfortunately neither technique seemed to work well. The study on the right just came out this year, and it's looking at younger patients, teenagers, who had ACL repairs done versus those who had a quadriceps tendon autograft. And unfortunately, the further out you go from surgery, we see that with the ACL repairs, the revision or failure rate goes up to 50% versus 5 to 10% for those who had the traditional reconstruction. So it does demonstrate that perhaps we haven't perfected ACL repairs yet. So some very innovative and very smart people are working on trying to make it better. And Martha Murray is an orthopedic surgeon in the Harvard system and up in Boston, who has this very cool technique where basically they're using a scaffold. And a scaffold is basically a collagen sponge. And they put stitches in the ACL, and then they'll put that collagen sponge between the ends of the torn ACL and add some blood. And that seems to increase the healing rate. And this is all very, very early. Okay, so she has some very early studies with very few people. But if you look at the top MRIs, where we see the ACL tear, so remember the ACL on this image is going to be diagonal. Unfortunately, I can't seem to show it there, but these are all ACL tears up on the top, and these are people who had the bear technique, which is where, again, they stitch the ACL and add the collagen sponge, and it seems, at least early on, to be remodeling into what the ACL used to be like. It's not perfect, but it seems to be getting there. So is there a role? Well, the jury's still out. It's not completely clear who are the best candidates for ACL repair. It's not completely clear what the best way to do ACL repair is. You'll probably hear more about it. I mean, it was written up in the New York Times, and that's when you jump the shark, when you're in the New York Times. But, it is promising, but at this point, for the high-risk athletes, I think most of us will likely still stick with the tried and true reconstruction.